There are basically 6 patterns that we look for in a muscle biopsy. Each pattern denotes a particular diagnosis. But as you can see in this table, the same pattern can be seen in more than one disease also. For instance, the first pattern here is an active myopathy with inflammation, which can occur in inflammatory myopathies as well as a muscular dystrophy. Pattern 2, which is active myopathy without inflammation, can be seen in inflammatory myopathies, muscular dystrophies, and even metabolic or toxic myopathies. Pattern 3 and 4, which are chronic myopathies, are common to muscular dystrophy, inclusion body myositis, and congenital myopathies. Pattern 5, which is a neurogenic atrophy, wherein the biopsy shows atrophic changes, has a very wide differential diagnosis. As in diffuse atrophy following steroids can be seen in endocrine myopathies and even myotonic dystrophies. The last pattern is a normal looking muscle. Now, a normal looking muscle may be because there is truly no pathology, but can also be because an unaffected muscle has been sampled, or it could be secondary to a metabolic myopathy. So what's very obvious from this slide is that there is a lot of overlap in muscle biopsy features between the various clinical entities. And therefore, the only way to reach an accurate diagnosis is by a close correlation with the clinical features. And this is the reason why we always insist that detailed clinical information must always accompany a biopsy. The more clinical details you provide your pathologist, the more accurate will be the diagnosis that is provided. In the next few slides, we'll quickly go through how the muscle biopsy appears in each of these 6 common pathology patterns. We will start in the reverse order. This is a completely normal muscle. On an H&E stain, you can appreciate the polygonal fibers that are closely opposed to each other, with all of the nuclei being peripherally placed. Next to this, in the upper right hand panel, is the modified Gomori trichrome stain. If there is no red seen, then you know it is completely normal. In the lower panel is the SDH, NADH stains and the ATPase stains, which show a typical alternating type 1 and type 2 fibers in a checkerboard pattern. So this is how a normal muscle looks in the various stains that we do. Compare that with what we see when there is a neurogenic atrophy. Now this neurogenic atrophy we know can result either from a disease of the anterior horn cell, the radicle, or a peripheral nerve. So this is a schematic representation of innervation of the myofibers by different anterior horn cells which form the motor units. If one of the anterior horn cell dies, as is shown in figure 2, the myofibers that it has innervated will either collapse or undergo atrophy, a process which we term as denervation. As a compensation, the adjacent anterior horn cell may innervate these fibers, and this leads to a grouping of similar fiber types, which is termed as the re-innervation. If there is death of the re-innervating anterior horn cell, then there will be atrophy of this entire group of fibers that it had re-innervated, and this feature is called as group atrophy. Now let's look at how this looks in a muscle biopsy. In the top left picture, you can see 4 small sized atrophic, what we term as scaphoid fibers in the center. These are how atrophic fibers look. And if these shrink even more, then all that will remain are a bag of nuclei, and this is what we term as nuclear clumps or muscle giant cells. Both of these features reflect denervation. In the lower left, you can see groups of small atrophic fibers, and you can also see this alternating with very large hypertrophied fibers. These have lost their polygonal shape and they've become more rounded. This hypertrophy tells you that it's a compensatory phenomenon, compensating for the several other fibers that are showing atrophy. What is important to note, however, is that there is no fibrosis or fibrous tissue between these myofibers. At places though, there is fat which is separating out the myofibers, and that you can see in the top right hand panel. But most importantly, there is no fibrosis that is occurring in the myofibers. These are the features that are very characteristic of a neurogenic pattern of atrophy. If we do an ATPase stain, you can see dramatic grouping of fiber types on the left hand side, which is in contrast to the checkerboard pattern of myofibers that you're seeing in a normal muscle on the right for comparison. The groups of atrophic fibers appear to be of both fiber types. They're both dark and light, and that is seen in the center. And this is flanked by fascicles which are showing fibers that are all of the same type. In this case, they're all type 2 fibers, dark on this ATPase stain, and this is the characteristic feature which tells you that there is re-innervation. We move on now to learn how to recognize myopathy, wherein the pathological changes are primarily in the myofibers. This is a schematic representation of the sequence of changes that we see in a myopathic process. The key change that is seen is necrosis of the muscle. The necrotic fibers lose their enveloping sarcolemmal membrane, and this is a very important structure because this is what keeps the myoglobin within the myofiber excluded from the immune system. So when the sarcolemma undergoes necrosis, it exposes the myoglobin to the immune system, and this elicits a lot of inflammatory response. The first cells that come in are the phagocytes or the macrophages, which come to scavenge the necrotic fiber, and this process we term as myophagocytosis. This is then followed by repair, wherein the satellite cells that surround every myofiber proliferate to help it to regenerate. These regenerated fibers can either undergo hypertrophy, which we recognize as increase in size and rounding, or if it loses its innervation, then it undergoes atrophy. This panel shows how these features of an active myopathic process appear in a muscle biopsy. In the top left panel, you can see arrowed a very pale pink fiber, and this is how a necrotic fiber looks, which is in stark contrast to the bright pink of all of the normal fibers that are surrounding it. In the next stage, you can see myophagocytosis, wherein there is invasion and phagocytosis by macrophages. In the lower left panel, there are collections of lymphoid cells in the interstitium, and on the right, you can see the characteristic regenerating fibers, which we recognize by their deep blue color. They are smaller in size compared to the adjacent normal bright pink myofibers, and they have very large nuclei, which are often in the center of the fibers. So these four features, the necrosis, the myophagocytosis, the regeneration and inflammation, are what characterize an acute myopathic process. In a chronic myopathy, in contrast, you can see that the fibers appear very large or hypertrophic, and some of them undergo splitting. The rounded fibers are no longer closely packed as in a normal muscle, but are widely separated by collagen, a feature which we term as endomysial fibrosis. Now this is dramatically brought out as a blue color, separating out the orange myofibers on a Mason trichrome stain. So chronic myopathy with prominent fibrosis of the endomysium is commonly seen in muscular dystrophies. So these are the most common pathological patterns seen, and each pattern, as we have seen, points out to a specific muscle disease. But as we have said before, there is considerable overlap of features between entities, and therefore correlation with the clinical features is mandatory for us to reach a final diagnosis.